I also wanted to talk maybe a little bit about Cohort K, which although was a different cohort, was a kind of a pretty similar population and treatment as well. So maybe can you comment on how that adds to the really the data you presented?
Yes, absolutely. So the Cohort K, as we discussed, is a randomized cohort to see what the combination added, which otherwise EV monotherapy did not achieve. And I think when it was first presented at ESMO last year, we saw that the consistent results were seen with EV pembro, right? The response rates were much higher than EV mono. The toxicity profile was pretty consistent. So I think that was more of reassuring cohort, and for the purposes of registration, FDA wants to see what the combination is doing in comparison with just the mono. So I wouldn't say that the activity there was anything surprising. Whatever we saw in the cohort A was pretty much reassured there. And the key was the durability. The EV mono by itself was not as durable as the EV pembro combination. And then that I think brings us to what you just mentioned. A lot of patients can drop off after initial platinum therapies, do not get maintenance avelumab for a variety of reasons. A lot of patients progress after initial platinum. So if we have a regimen that in the frontline setting can keep these patients going for as long as they can tolerate and it derive benefit, it's really important.
Yeah, no, absolutely. And I think that that actually sort of leads into my next question, which is, platinum therapy, and at least is finite, although then avelumab maintenance we continue until progression. In this EV-103 regimen of EV pembro, you technically continue it indefinitely, but often what limits the patient's time on it are toxicities. So I was hoping you would also comment on really the toxicity profile of this regimen, and if after 4 years of follow-up you did see any additional signals there.
So the toxicity profile of the combination, the key toxicities are rash, peripheral neuropathy, hyperglycemia, and something that we observed in this cohort was that there's increased incidence of bullous dermatitis-like rashes, which we otherwise don't see just with pembro monotherapy. In fact, there was a toxic death with this. So that was something that we want the providers to be aware of, that rash needs to be examined for at every visit, and treatment held or doses reduced accordingly. And peripheral neuropathy is another thing, right? As you know, Vadim, patients who are on chemotherapy, are very vocal about their toxicities, like neuropathy and other things. In my experience and in others' experience, patients sometimes understate their toxicities from drugs like EV and immunotherapy. And many times, when we make them walk, like they have this severe motor functions, which they would just downplay. So I think it's important to understand that peripheral neuropathy is something which can really get disabling and limit our further ability to treat the patient at all. So it's important to be quick to adjusting the doses, holding doses, giving treatment breaks, and going from there. And again, we saw some lipase increases, which were not clinically meaningful, but this combination can lead to diabetes, diabetic ketoacidosis, even in patients who are not baseline diabetic. So these unique toxicities, which are seen with this combination, need to be, evaluated when we're treating patients. And I think the treatment duration is $1 million question. I really don't think everybody needs lifelong treatment of EV. Pembrolizumab does stop at 2 years in the EV-302, but EV is the main driver for the initial benefit. So I think intensifying it early on and then continuing pembro maintenance is something that we would like to evaluate in future. But for now, in my practice, I'm very quick to decreasing the doses, holding the doses, because if patients are benefiting, they still continue to benefit.
Yeah, and I think that is actually a really, really critical point that you made about many patients with enfortumab actually, well, yeah, sometimes actually underplaying their symptoms, particularly the neuropathy, right? And which can be pretty insidious and sort of develop slowly over time. And I think any provider using this drug needs to be very, very vigilant about this and be pretty aggressive with actually reducing dose, and then
Yes.
as a result keeping patients on drug longer. Well, with that, the EV and Pembro, this combination now has accelerated approval in the United States. We can actually use it. And I wonder if you can comment on first of all, whether this is something that you do consider practice-changing data, and this has changed your practice. And if so, how do you select for cisplatin-ineligible frontline patients, whether you give them EV pembrolizumab or still stick with carboplatin and maybe avelumab?
Yeah, that's a great question, Vadim. So this is an additional option. We do discuss it with our patients. I think, once we have the survival data available, we'll offer it more universally. As of now, it has not changed my practice completely. Based on the Javelin Bladder 100, we have an intensification maintenance trial, the main CAP trial, where we are adding cabozantinib to avelumab. So we also offer patients that. And for some select patients right now, if somebody has some comorbidities, which will sway me either way, I use that as a deciding factor. For example, in poorly controlled diabetics or obese patients, I don't think EV Pembro is the way to go unless, we control the diabetes. And same for patients who are having some really baseline neuropathy, where we know, neuropathy with EV is much more than what you would see with carbo. So I think those are the factors I decide for what treatment to give. If somebody has really bulky liver metastases, we need a rapid response. I think this is really, especially because of the exquisite activity in the liver lesions. But I will just say that, I do follow the level 1 evidence wherever I can, and use this as a discussion point to offer this to patients if they do not want the chemo followed by avelumab.
Yeah, absolutely. Yeah, and it's great to have this as an additional option, but I think we're still waiting on the randomized data from EV-302 to really probably confirm a lot of this practice.